The study that we presented summarized data, efficacy, and safety of epcoritamab monotherapy in patients with relapsed refractory chronic lymphocytic. This is an ongoing phase 1/2 study which enrolls patients with relapsed refractory CLL who have progressed after at least 2 prior lines of therapy. And the study had 2 cohorts, the expansion cohort and the optimization cohort. And there were some distinctions between the two, where during optimization cohort, there was an additional step-up dose of epcoritamab administered. There was some mandated steroid and dexamethasone use and mandated hydration. And the overall goal of the study was response rate for the expansion cohort and certain safety measures for the optimization cohort. The results of the study basically come in 2 groups. First, if we talk about safety, it is important to highlight that epcoritamab was, in general, well tolerated by patients with CLL. As you know, epcoritamab is already approved in patients with relapsed refractory follicular lymphoma and diffuse large B-cell lymphoma who underwent lines of therapy. But this is the first time it's being used in chronic lymphocytic leukemia. And it's an agent which is administered subcutaneously. And just like other bispecific antibodies, it is associated with certain particular adverse events, particularly cytokine release syndrome. So in this study, we have seen some anemia and thrombocytopenia, which are very common in patients with CLL. And in fact, the majority of patients who reported these 2 adverse events had pre-existing anemia and thrombocytopenia going into the study. But other adverse events were quite tolerable. There was low-grade diarrhea, fatigue, nausea, and most of them were transient. And treatment discontinuation due to adverse events was rare. Only 5 patients discontinued in expansion cohort and 1 patient from optimization cohort. What also is important to note is that in the optimization cohort, the grade of CRS was significantly decreased. Both the frequency of CRS, which went down from 96% to 82%, and again, the grade. Most cases were grade 1. There were no grade 3 CRS in the optimization cohort, and treatment and the use of tocilizumab was significantly less frequent in that cohort. Also, there were no cases of ICANS. And as we are used to seeing that, cases of CRS occurred with the first full dose of epcoritamab, which would be when epcoritamab is administered at 48 milligram dose. And the second part of the study is efficacy, and that has mostly been so far assessed in the expansion cohort, which long follow-up of 23 months. And in that cohort, among response evaluable patients, response rate was 67% and response 43%. And to know that responses were maintained in patients with high-risk disease, including TP53 aberration, IGHV mutated status, and patients who were double refractory to ibrutinib and venetoclax. In fact, this patient population was highly refractory with 4 million prior lines of therapy, and vast majority progressed on ibrutinib and venetoclax. And therefore, in this patient population, such high response rate for a single agent is, I believe it is a big success. Optimization cohort so far has a fairly short follow-up of 3 months. However, we do see similar response rate, although complete responses are still, it's still too early to determine the true frequency of complete responses. So those are the results of the study. Well, patients with CLL which progress on novel agents, ibrutinib and venetoclax, or other BTK inhibitors, represent an unmet medical need. So really, we don't have very effective therapies for these patients. Chemotherapy doesn't work. We do have pirtobrutinib, which works. However, progression-free survival is on the order of 1 year, a little bit over 1 year. CAR T cells also have been approved for this patient population. However, they are associated with high toxicity and high infectious rate. So far, I'd say the treatments for these patients are limited and suboptimal in their efficacy. So this is a new state-of-the-art technology, bispecific T-cell engager approach, which I believe can really eventually change how we treat double refractory CLL. And also, it is important to note that bispecific antibodies have been shown to exhibit synergy with targeted agents. So I believe that moving this agent into earlier lines of therapy is also something that we should be doing.